Hello and welcome to the Spinal Nerd Podcast. My name is Dr. Brian Hoves,
And my name is Dr. Jason Kung.
and thank you guys for joining us today. Dr. Kung, thank you for joining us as well. I feel like I have to stop welcoming you now that you're the official co-host of the podcast. Uh,
Oh, co-host, very nice. Sidekick, maybe. Yeah.
sidekick.
Thank
I
you.
like that.
Thank you.
I've never had a sidekick before. I like that. So it's currently the middle of February 2024, and one of the things that happened last month that I didn't get to partake in was the North American Neuromodulation Society meeting. And I think we had talked about it a little bit at last one that you were going to be headed there. So wanted to pick your brain. How was the meeting?
Yeah, I went. It was just for about 36 hours, so just a quick trip. Thankfully, we live close to Las Vegas, so quick flight in and out. It was great catching up with a lot of folks in the field from fellowship and just from talking with folks about the space and meeting people that I've never met in person, but spoken with virtually. So I think the catching up part was really nice. It is
Yeah.
definitely a good place to do that. Um, and checking out the exhibit hall and the all the new, just so many new companies out there. It was interesting. I think the theme for me was SI joint fusion. Uh,
Yeah.
it, it did seem like you everywhere you turn was a new sacroiliac joint fusion company, mostly the posterior approach, and some with the oblique screws. So yeah, I think that was taking up maybe like 25% of the exhibit hall. It was
Wow.
very interesting.
Yeah, I mean, it's been a few years since I've been to the meeting, but I believe in 2020 there was two companies that did SI joint fusion. And SI Bone was there, and I believe Pain Tech was there, and I don't think there was
Mhm.
just anybody else. Corner Lock might have been there at that time. Um, yeah, definitely not anywhere near a quarter of the space on the floor. I mean, you're talking about, very, very small booths off to the sides. So interesting difference in the development of the space.
Yeah, I didn't see any big announcements as far as the neuromodulation space. This meeting, there wasn't any major new waveform. We're going to get into a little bit about the closed loop technology. So, obviously, some of those players were there, but I didn't see anything from that standpoint that was major breakthrough. But I think there was a lot of MRI compatibility discussion. So I think that was probably the highlight as far as neuromodulation. I guess moving away from just who's got the best waveform to other metrics that also play into the factors of whether a patient gets relief or not.
Yeah, I think it's probably one of the best things I would say of the development of the space. And obviously, with as the technology is developed, I think that there is so much great technology in the space, and there's so many great things for patients to have exposure to or have access to. um, but yes, the fact that it's not this waveform versus that waveform, and that's the end all be all of the conversation, but realizing that there's so many other factors that play into patient success, right? And how well these devices actually do as we're treating patients, rather than thinking theoretically about what's best in a vacuum, this sign or the sign or the sign. So yeah, I think that is a maturation, hopefully, of the space, is being able to really understand that there's many factors that play into the patient success. And
Mhm.
obviously MRI being a really big factor, I guess. Maybe depending on who's speaking on stage, more or less of a factor. But I think both of us would agree that MRI is a pretty significant thing that we think about when we think about our patients.
Yeah, that I guess that kind of parlays it into this the study that came out last year. It was by Mullins et al. It was a retrospective review, basically looking at all the MRI conditional systems, specifically looking at the impedance dependent MRI conditional SCS systems. Um, so we'll just briefly go over it. I'm not going to get into too much of the weeds, but they looked at 363 cases, so about 600 leads total. And the interesting thing here is, the lead survival time for a normal lead impedance is about 4.7 years. So I guess, what that means is that in 4.7 years, that's how long a lead will stay with completely normal impedances. That's the average time. I guess, after that, you can have high impedances and certain electrodes. So that was kind of interesting to see. And then overall with those cases, they found that 18.5% of patients had had very high lead impedances over 10,000 ohms. Most common was with one lead impedance, about 40%. With two, I think they're talking about electrodes. I think that's what one electrode. So one high impedance electrode was about 40%. Two of them was 22%, and three was 12%. And they looked at all the companies that were, had the impedance dependent MRI conditionality. And that's covering Abbott, Nevro, and Boston. So, just an interesting thing to, counsel patients on. And that's why we have redundancy. We have usually placed two leads if possible. There's multiple electrodes, multiple contacts to try to mitigate, if one goes out, we can program around it.
Yeah, and if I remember correctly, when they were actually looking at those quoted numbers for the impedances, I know you said that the 4.5, 4.7 years was the kind of the overall lead survival time, but I think the actual 18-20% number that you quoted was at like 2.5 years.
Okay.
So I think that basically to kind of summarize it or put it in layman's terms, right? Roughly 20% of the MRI conditional systems are not MRI compatible at 2.5 years, which is
wild.
Which is pretty wild, right? I mean, that's definitely not something that they're going to put in the pamphlets when we're talking about MRI conditionality, right? I mean, that's a pretty significant number. I mean, I think, and then if you put that side by side with the studies that have looked at how many patients that need a device actually need an MRI, and I think those studies were over the next 5 years. They kind of put it out in the, I think it was 85% of patients would theoretically need an MRI or would be best suited by an additional MRI within 5 years. And so, that's a pretty, I think that's a pretty staggering percentage, right? To get that 18% of not able to utilize that MRI conditionality.
Yeah, no one likes doing explants primarily for, getting an MRI. You do it for the patient, and they definitely need it. But each time it happens for me when I have to do it, it's a little bit discouraging that we should be really pushing for having these devices be basically MRI compatible with some very small exceptions.
Yeah, I think that makes a lot of sense, and hopefully it's an area that, obviously I think people are paying attention to it. I mean, I think it's something that everybody talks about. It's just a matter of hopefully that technology continuing to evolve, that everybody gets to that point, because hopefully people are paying attention to that number. I think it's a pretty staggering number, and definitely something that you really do need to let patients know if when using those systems.
Yeah. I think as far as hopefully that will be standard of care in the future, with having these devices more friendly with MRI. I think the next thing I want to at least go over, it's not anything hot off the presses, with ECAPs or both compound action potentials, but wasn't also, this is not hot off the press from NANS this year, but the 36-month data from the Evoke trial came out last year. I don't think we talked about it yet, but I think it's worth discussing just because it's 36 months. That number and neuromodulation haven't really been put in the same sentence for. I don't think, maybe I'm missing something, but I've never seen a study that looks out these are randomized double-blind trials looking, going out to 36 months. So I do think it's worth kind of going over because this technology is coming. And if it is as described in the study, it's quite remarkable as what it's able to offer patients.
Can for the those listening that may not know what ECAPS is or what the Evoke study is, can you just give us a little kind of background on what that means and why it's different from other forms of spinal cord stimulation?
Yeah, I think the best way to describe it is, well, at least the way that I've been describing is kind of like how a pacemaker is able to both sense the intrinsic rhythm of a patient and then react to it, versus kind of a one-sided putting in an input and then, depending on the patient's subjective feelings, changing those inputs. And that's really been all neuromodulation companies right now is basically, they come in, they meet with the representative, they program them based off the patient's symptomatic subjective response to whatever milliamps or pulse width that they've programmed, and they get programs. And then, sometimes we have to go in and change it. It's gotten much better nowadays, but with ECAPS, we're basically able to measure how strong the dorsal columns are being stimulated without the patient having to tell us. I'm not a engineer, biology major, pretty boring for med school applications. If you're going into med school, don't major in biology, do the pre-med classes and do something else. But as far as my understanding of it, it's we're with closed loop stimulation, we can measure how many nerve fibers are being activated by a single electrical input. And by doing this, we can use it as a proxy as to how many dorsal column fibers have been activated. We can basically measure how much of a charge that is needed to elicit an ECAP. Everyone's different. Position is different. Patient weight, coughing, sneezing, those all change, how much of the dorsal columns are being stimulated. And when you're able to turn up and down the electrical dose or the charge needed to stimulate it, you can basically get a more consistent activation of the neural tissue, and it minimizes both the understimulation that people will get and also the overstimulation.
Yeah,
so that's my thought on
I think
that's my understanding of it.
I think that was very good. I would have used much simpler terminology to talk about it. But right, evoked compound action potentials. And so, yeah, I mean, basically, you hit the nail on the head in very technical terms, but right, two-way feedback essentially, right? It senses and then it responds based off of that sensation. Mm-hmm. I think anybody who has utilized a spinal cord stimulator has, seen when a patient, if they kind of move in the wrong way, especially early on, and they'll talk about getting a big zap, right? That's kind of that overstimulation that you were describing, and trying to figure out ways mm-hmm. to limit that and to make sure that, yeah, like you said, the consistency is there of appropriately stimulating the neurons that we're planning on, neurons and glial cells. Mm-hmm. Otherwise, I would remiss not to give a shout out to Dr. Carvelis anytime I say glial cells. So glial cells, sir. So catch us up on the study. So we got 36-month data. So long-term study.
Right. Yeah.
Longer than most spinal cord stimulators are capable of having an MRI. I shouldn't say most. 20% of implanted stimulators are able of having an MRI.
Right. So the original study was from 2020. That was an ID study, so they looked at 36 months out. So just briefly, the population was just patients with chronic intractable back and leg pain, refractory to conservative treatment. The intervention was ECAP versus open loop spinal cord stimulation. So interesting thing, the Saluda device. Saluda is the company that makes this ECAP capable spinal cord stimulator. They're able to basically program the the IPG to be either in the closed loop function or in the traditional open loop function. So they basically use the same IPG and just compared them to each other. Their primary outcome was looking for a pain reduction of more than 50%. They had a bunch of secondary outcomes looking at holistic treatment responses, physical and emotional functioning, et cetera, sleep, quality of life. So 134 patients were enrolled, 113 went for permanent implant, and they basically split them in half, and they allowed the patients to cross over at 24 months. So some thoughts here, they found that the open loop spinal cord stimulator patients were more likely to cross over. The closed loop patients also crossed over, and their main reason was just curiosity as what the other option was. The main reason for open loop crossover was hope for improved pain relief. So I guess you can think that maybe the open loop patients weren't feeling it as weren't getting as much benefit possibly. And then 80% of the people that did cross over stayed in the closed loop arm. So 80% of the people that crossed over to the closed loop decided to stay there. They went into a little bit of the programming. I don't know the details on it, but regardless of whether they were in a closed or open loop arm, they were both programmed with the using ECAPs. This is fundamentally different way of programming patients. So they found that the battery depletion rates were similar, so 6-7 days, I think. Let's see other things about the device. So there were explants, about 18 explants out of the 113. The most common reason was the need for an MRI, 28%. Loss of efficacy. Looks like the explant for that reason only came from the open loop arm, and then infection about 1.8 to 3.6%, which is kind of on par. So really the outcomes at 36 months, looking at the primary outcome of a greater than 50% reduction in back and leg pain. So that outcome was significantly greater for closed loop and open loop. So 78% versus 50% or 49%. There were no non-responders in the closed loop arm and only 10% in the open loop. So I think, the study is much longer and it has, all the secondary outcomes, but just looking at this, it's, I think the efficacy rates, especially for the closed loop, seem to be on par with some of the other pivotal spinal cord stimulator studies in the past. But I think the biggest thing for me was that it's 36 months, and this is much longer time. The MRI compatibility, I think that's actually changed as of last year. I think before it was MRI unsafe. I think now it's MRI conditional. It's hard to find the details as to what are the measures, but it's they're there. You just got to find on the internet somewhere. I looked at the manual. It still says it's MRI unsafe. I'm sure they're getting ready to update that, but just
stuff. Yeah.
Yeah.
I think this study was, like you said, the most interesting thing is obviously 36 months, taking it beyond the 12 and 24 months that we generally see with most of the big studies. 80% responders, responders being greater than 50% pain relief, basically does put you in the same range as most of the other, with all of the studies that looked at the different waveforms, right? And so whether you're, I think that's, to be seen what it looks like out in the real world, I think is basically the way that I take that. I think one of the things that, that one way you could interpret this is that their programming method in open loop is inferior to the other, the data from the other studies that have
right.
Obviously this is out to 36 months, but I think they were just under 50% or right at
it's at 49.3.
Yeah. So, right. And so of patients responding with greater than 50% relief. And so, I think maybe that's, obviously a challenge of this study is that they're open loop programming is not necessarily what we've seen with the data from the other open loop programs that are there. And so just so everybody's aware, whether we're talking of high frequency stim, whether we're talking of burst, or whether we're talking DTM, or even I think with the fast programming that
Yeah.
Boston's recently published. I think all of those in their clinical trials have responder rates generally between 70 and 80%. And so, I mean, that's, if you're looking at just the comparison group for open loop, that does, you know, but the system wasn't designed to be an open loop system, right? And so
Right.
that's that's where they're kind of on par, like you said. And so I think a lot of people are really interested. I'm really interested to see what all this looks like out in the real world,
Hmm.
because there's been a lot of data that has been published over the past decade of looking through neuromodulation, and some of it is translated really well for a lot of people, and some of it hasn't translated really well to real world outcomes for people. And whether that's just I don't know, something about patient selection, or just a difference of in an individual's hands. I think that's what we're all looking and anxiously
Hmm.
waiting to be able to see.
Yeah. Speaking of patient selection, I know that our colleagues down the road over at UC Davis and Stanford just published like a neuromodulation like selection committee
Yeah,
thing. I thought that was a really cool study. I
yeah,
think you shared that with me a few weeks ago.
yeah,
Really cool. Great
yeah,
idea.
yeah. I mean, I think it was very a very interesting way of being able to look at it, right? I mean, particularly from when you think of an academic center and you think of training, like, to be able to truly have a multiple brilliant minds kind of talking about you know their reasoning for or against these different tools for some of these patients. Yeah, I think it definitely makes for a great learning experience, obviously for the fellows, but obviously just hopefully a way of being able to translate significantly better outcomes for patients.
When I first read that, it reminded me of like the tumor boards when you have surgeons in the room, you have the oncologists, you have the hematologists, you have the whole just multidisciplinary team, and all looking at the same patients. What's the right thing to do? It basically kind of sounds like that, and it makes sense. I think pain medicine has a lot of catching up to do in a lot of areas. But the fact that we're thinking a little bit not outside the box, is it already this kind of group thinking already exists. Why not translate it over to what we do? I think it's a great idea.
Yeah, yeah, I know when I first read that, and I've been actually trying to reach out to Dr. Scott Pritzloff, trying to see if we can get him on to kind of talk a little bit more. I wanted to talk a little bit more about the just all of the changes that they've been doing at UC Davis as far as their education is concerned, but specifically about this. When I texted you the study, I was like, this would be really interesting for us as a practice to do, right? I mean,
Yeah.
we're a medium sized multi-location practice, and so I know I like to reach out to Dr. Kung often whenever we're having some interesting or some challenging patients, and pick a brains. But I think it'd be really great, we have 10 physicians in the practice to be able to actually sit down, and we do that, we do some of this, but I think most of our
Right.
conversations tend to be um, less procedurally based, and tend to be more focused on you know
Mhm.
some of the other difficult aspects of patient care. And so
Right.
I think, to be able to present some of these cases and talk through them can definitely be great for some of our younger physicians, but also just great for all of us to, really understand, different ways of using it, right? Because, we all trained in different places, we all have different experience, and, being able to see like, oh yeah, I had a patient with chemo-induced neuropathy that actually did really well with this and with these settings, and or something along those lines, because there are many things that we treat that are you know pretty challenging, and that are there's definitely not a large randomized controlled trial for every single diagnosis. Chemo-induced
Mhm.
neuropathy as one of them, right? I mean, we have indications for diabetic peripheral neuropathy because there's the volume of patients is there, but it becomes a lot harder when you start extrapolating that to some other things.
yeah, I think, then when I went into private practice, I had another job before, and it's I kind of felt like I was on my own a little bit, just figuring it out. Um, and now with spinal nerve, it's been, I definitely have I can reach out to you. We have set time to kind of talk to basically all the providers in practice. So I think just because you go into private practice, it does not mean that you're going to be on your own and you're just going to have to figure it out by yourself. I mean, you can set up something where you're kind of working as a collective, as a team, similar to academics, obviously different in a lot of ways, but to have someone look at how you're treating a patient, whether it's you think it's the right way, whether there's better ways to do it. So yeah, I would be interested. We should get this. We should definitely try to work this into our practice. I think that would be a really cool thing.
Yeah, yeah, and that's one of the awesome things about people like UC Davis and Stanford and Scott and their whole team over there. Being able to lead the way, right? Give us an example of like what they're working on and publishing in it, so that way we can kind of extrapolate that and find ways to be able to incorporate that in our practice. So that we can keep getting better. And so that we can keep trying to deliver, better outcomes and better care for our patients. So Scott, if you're, I know at some point you'll probably hear this. If not, your fellows will hear this and they're going to know that I'm talking to you, because I know your fellows listen. Um, but we'll have you on the show soon, because I do think that a lot of the things that you guys have been doing are really interesting, and this being
Sure.
one of the most interesting ones.
Are we studied out, or should we go over
Yeah,
this
yeah,
other
yeah. You have one
really
more you want to
interesting
go
one?
over?
I don't think we need to go into too much detail on this one. I just thought it was an interesting one that I haven't seen anything looking at paraspinal muscle atrophy and how it affects your vertebral endplates.
Oh yeah, 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 yeah. That's
Yeah,
great. I like that. I like that study too. I remember we did talk about that one.
yeah.
Now here's a question: can you pronounce the name so that way you can properly quote the study, or do we just have to reference them in the show notes?
As a way to save face and not butcher uh, our colleagues across the pond, and um,
Yep,
no.
that's fair. All right, guys, it'll be in the show notes. All four studies that we've talked about will be in the show
Yeah.
notes today. Um, but yeah, sorry. Go ahead. Didn't mean to interrupt. I just was wondering if you were going to try to take a stab at that last name.
uh, so it's a 3-year longitudinal retrospective analysis of and just basically looking at the association between the paraspinal muscles and end plate degeneration. They go into a little bit of how the paraspinal muscles kind of act as like a counter support to the spine, similar to like a crane has that counterweight on the other side versus the other side where it's doing all the work. So there's been a lot of research into paraspinal muscles and how they can be a pain generator. I know there's a lot of companies out there that are specifically targeting mechanical back pain from this general area. But this study was looking just seeing what the association was with end plate degeneration, and they assessed it by a total end plate score. And then they also looked at the fatty infiltration of the paraspinal muscles. Um, and it looks like the fatty infiltration of the paraspinal muscles was significantly associated with the total end plate score, um, and also the progression of end plate degeneration. Um, so yeah, I'm not going to get into too much with the rest of the study, but there's some nice pictures on there. I know we've talked about uh, basic vertebral nerve ablation a few times on our pod this year, but I think this is just something to also know that if you see it on your MRI, you can still physical therapy is still a cornerstone, no matter what we do, no matter if we burn the basic vertebral nerve or do a stimulator. I mean, you have to work on these paraspinal muscles, because the more fatty atrophy that goes into it, the more degeneration in the spine, which makes logical sense to me. But just to see it in this, with pictures and so with this study, I think it was really, had some good insight.
Yeah. One of the things I really found interesting about the study was, I mean, just the rate, right? I mean, I don't know how much any of us think that you can see that significant of changes in 3 years. And so, I mean, to have a pretty significant change in the actual amount of end plate
Mm.
degeneration in a relatively short time, because the patients weren't that old. I think they were from late
No,
50s, 60-ish.
yeah,
Yeah.
exactly. And
Um,
then the median age was, the median BMI was 25
yeah. So
also.
not super large patients, and this is and not an American population.
Hmm.
And so not super old, not super overweight, but like a pretty significant change in a relatively short amount of time, right? And what they used for fatty infiltration was 40%. Um, and for better or worse, here in America, when we're looking at MRIs, um, I would say that probably almost every single MRI that I look at has more than 40% fatty infiltration into the paraspinal muscles, right? I mean,
Yeah.
it is very rare. I probably rare enough that I actually notice when there's not that much fatty infiltration into the muscles, or when the lumbar paraspinal muscles aren't significantly undersized compared to what you would expect for that size of a person. And so like obviously for our patient population, like this is everybody, right? I mean, like this is
Right.
there are very few patients that don't fall into that demographic, and for better or worse, here in America, the vast majority of the patients are going to be over a BMI of 25. um,
Right.
and for a lot of us, the vast majority of our patients are quite a bit older than 59, right? And so
Yeah.
that's to see that level of progression in those statistics, just like you said, just more things to think about, right? We're always making sure we're talking about core strength and working on a lot of that flexibility. I'll never stop telling patients to do some Pilates or yoga, and as part of the overall plan, because it's just such an important aspect of it. Like you said, no matter what else we do, if we can't at least help with that component of things are just going to kind of continue
Hmm.
to progress, right?
Glute bridge. I've been on the glute bridge train, both for myself, just doing that multiple times a week. And if you ever see me in clinic, that's the one. I'm not a physical therapist, but that's the one thing I recommend for patients. It's relatively simple to do, and I feel like it does activate those paraspinal muscles pretty good.
Yeah. Yeah, it's if it's something simple, right? It's always just about being able to give them something simple and actionable, some way that we can be able to activate these muscles that obviously a lot of people aren't activating in the
Hmm.
appropriate manner. And then one day, hopefully, they can start to develop guns like you, Dr. Cohn. All right,
Any
four
other studies?
studies.
I don't think. Yeah, I think I'm studied out.
Yeah,
I might be studied out.
I think it's a good amount. And they all
Yeah.
kind of flow together too. I like the
Yeah.
way that you set that up. I think it worked really well.
Okay. All right. Well, it'll be definitely interesting to see this year with. Um, there's going to be some announcements in the neuromod space. I think with the next few months, and it'll be interesting to see how all that plays out, and the data coming from that. Um, New topics. We'll be brainstorming. I guess if anyone has any ideas, they can also reach out to us.
Yeah, no, definitely interested to see how things continue to evolve. I think there's a lot of people paying attention to this closed looped idea, and hoping that if you can kind of partner that with some of the other tools that have already been brought to market, wondering if you can just optimize the other waveforms, or the other tools that are already there, right? And so I think that'll be really interesting to watch develop over the rest of the year and into next. And hopefully just continue to work on better and better technology and better options for our patients.
Agreed.
Awesome. Well, if you guys made it this far, thank you guys very much. It was awesome. I hope you guys learned something. We had a nice little journal club, and hopefully learned a little bit more about neuromodulation, kind of digesting I think maybe not stuff that was necessarily front and center this year at NANS, but anytime you're thinking about
Mhm.
NANS, you want to talk about some of the neuromodulatory ways that we can help our patients. And so, thank you guys for making this far. Please send a message to Dr. Kung, tell him you think he did a good job setting up our flow for this week. He really likes to hear from you guys. I don't know if he has yet, but I know Dr. Carvelis always would get very very touched when people reached out to him because he didn't know anybody actually listened to us talking.
Well, I
So
finally updated my LinkedIn
I'm so proud of you.
after years. After years,
You
it was
you
a
had
picture of me in residency, I think.
yeah, you had
Oh,
anesthesia resident listed for a very long time, and so
yeah.
it's good. So you guys can see an updated picture of Dr. Kung if you guys go to LinkedIn, and you can find him there, and see what he looks like as a fully grown adult instead of as a young man as he was about a month ago on LinkedIn.
I'm a big boy now.
But yeah, thank you guys so much. Keep listening, keep sharing the podcast with everybody out there, and we will talk to you guys next time.
See ya.